Hi, good afternoon, everyone. On behalf of myself, Mark Sandrock, and my co-moderator, Wendy Spearman, and as well as Project ECHO of University of New Mexico, Albuquerque. We welcome you to this month's Department of Medicine COVID-19 webinar. It's become a highlight on the calendar over the last 18 months during the pandemic, and this afternoon will be no different. Before I hand you over to your chair for the afternoon, Professor Graham Mankies, to really go through what again is a fantastic agenda. Remind you that we will be taking some questions in the chat in the second half, and you will be alerted to when you can do that. Again, thank you very much for joining, and as always, thank you to Cheryl Valentine, Zahana Rangel, and the Department of Medicine staff for allowing us and enabling this webinar. Graham, over to you.
Thanks very much, Mark, and welcome to everyone. We've got a very exciting program lined up for this afternoon. We're going to start off with our usual update from the Western Cape in terms of the epidemic, and then the focus really shifts to treatments for COVID-19, and we've got two presentations from international speakers, both of them with links to South Africa, and I'll go into that in a bit more detail. But they're going to focus on two therapies that have, in the recent time, shown to be of benefit in clinical trials for the treatment of COVID-19 in outpatient settings. But before we have our main talks, we've got our usual focus on the epidemiology, and it's going to be two presenters today, Andrew Bull, who this audience knows well, and then Reshma Kasanji. Reshma is a senior biostatistician within the Center for Infectious Disease Epidemiology and Research at UCT, or CIDA. And they're going to give us an update on the epidemic, but also some preliminary results from the Sisonke trial of the Johnson & Johnson vaccine in healthcare workers. So over to you, Andrew and Reshma. Thanks very much.
Thanks very much, Graham, and organizers. Greetings to everyone. Can I just check that you can hear me and see the slides?
Yeah, both correct. Yep.
Great. Okay, so I'm going to be very brief in going through the epidemic update, because we want to talk about the Sisonke trial later. So when we last presented, when Marianne, I think, presented a month ago, we were well into the third wave, and I think questioning whether we were peaking at that moment. We had seen, if you look at the black line, so the grey are the cases, and the black line is the active cases at a point in time, and it looked like it was starting to plateau at that point. But actually, subsequent to that, and it was just after the relaxing of the lockdown, we continue to have quite a strong rise in cases, and also hospitalization continued to rise for a while after that, and to some extent deaths as well. But we now have gotten over the highest event rates for deaths and hospitalizations. So just to orientate you, green at the top here is our public sector oxygen use. It's the bulk supplies that are updated daily from the public hospitals, is a very good barometer of acute care needs. Blue is patients in hospital, public and private sector. The dotted red is the excess deaths from the MRC measure. The solid red is our recorded deaths in the province with confirmed COVID-19 diagnoses. What's quite interesting is that the number of hospital beds that were occupied at the peak was very similar to what it was in the second wave, but for lower mortality. And we have a sense that the breaching of capacity was not as bad this time around. So the services were probably as stretched, but there were not as many people who couldn't access services. The public and private sector were not completely aligned in the same way as previously. So the number of patients in hospital for every patient dying didn't lower as much as it lowered during the second wave, which was probably a good thing for clinical care. But the other thing is that the peak was much more drawn out than our second wave or Gauteng's third wave. So if you look at the area under the curve, even for deaths, would seem a lot lower the total number of deaths that are accumulating in this wave are probably going to exceed what we had in the second wave. So it has been a very brutal clinical experience, and is still ongoing. Just to look at the geographic spread, the cases are coming down across the board, and the reproduction number is below 1 in all the districts. You can see that Garden Route was a lot earlier in the second wave, was still a little bit earlier in this wave, and some of the other non-metro districts were a little bit later, but they all are coming down now. And within the metro, all the sub-districts are, the active cases are coming down, and all the other metrics as well. You can see that to some extent, the Khayelitsha and Eastern and Khayelitsha Eastern substructure is running a little bit later. So Khayelitsha in orange, and I think the darker blue here, but they look like they are plateauing or coming down. So it is it does feel like it may be easing across the province. To talk very briefly about vaccinations, so there has been quite an increase in the daily vaccinations with the increase to 18 to 34-year-olds with availability. So at this point in time, 30% of the adult population of 5 million have had 1 dose of a vaccine, and there's probably we're approaching 1 million people fully vaccinated, either 2 doses of Pfizer or 1 dose of J&J. And you can kind of get a sense of how the age bands and the vaccination spread over ages is playing out. And then in terms of impact, we haven't formally assessed the population impact of the population vaccination program, but we do expect to see, with vaccines being more effective for severe clinical events than mild clinical events, that we'd see a kind of a gradient effect that we would see for populations that have higher vaccination. We'd see fewer cases, still fewer admissions, and still fewer deaths. And we're starting to see some of that gradient emerging for the over 60s, who are the group that have now have quite a high proportion fully vaccinated. So 65% of over 60s have had 1 vaccine dose, but about 50% are now fully vaccinated. And we will, in due course, try and do the type of analyses we're going to describe today on the at a population level, not just on healthcare workers. And then this is just shared from the Network for Genomic Surveillance. There was concern in the last week around the new variant C12. Which has emerged in 8 of the 9 provinces. And just to say that the data that has been shared with us for the Western Cape is that there have been very few cases, I think 3 represented here, and that we only have data, we don't have data from the last few weeks, so we don't know how it's played out subsequently. But at this point in time, although it's a variant of concern, it's not very prevalent in the genomic data available to us. To move on to the Sisonke study, which was the early access to healthcare workers in an extended trial setting to the single-dose Johnson & Johnson vaccine. Almost 500,000 healthcare workers in the country access this program, and 90,000 in the Western Cape. And today we're reporting just on the 22,000 vaccinees in the public sector. It's the public sector workforce of the Western Cape, healthcare workers who are registered as public sector healthcare workers, who are a smaller subset of the 90,000 in the Western Cape who were vaccinated. And the reason for this is it was the only group on which we had a representative group of unvaccinated people, whereas this broader group of healthcare workers was quite a broad categorization of healthcare workers. And our analysis is probably the smallest and probably the least robust of the analyses that have been done to evaluate Sisonke. There is about 100,000 of these 500,000 people who accessed vaccination in the study were matched to Discovery insurance, medical aid, and 2/3 of them could be included in an analysis, and they were able to compare people with unvaccinated, an unvaccinated cohort, and Reshma will describe that study design in a moment. And similarly, med scheme with a large public sector benefit scheme, were able to match a large number of patients, over 100,000 included in their analysis. And so those two medical insurance analyses are much larger than the Western Cape analysis, and they were able to try and ensure equivalent risk in vaccinated and unvaccinated in a way that we are probably not able to. But our study will include some uninsured people and does have the coherence of all being working in a single healthcare system. These are the headline results that have already been shared by the Sisonke study, by the study leads in different forums. And the headline is that around there's about a two-thirds protection against hospitalization in the largest of the analyses at that point, which was the discovery analysis, and a gradient effect of greater effect in protection against mortality. And this is in the paired cohort of vaccinated individuals with an unvaccinated comparison cohort. This is the surveillance data of infections and in the general population and in healthcare workers. So the solid line is the 3 waves, cases at the top and admissions at the bottom. For the general population, the dotted line is healthcare workers. And we do see that gradient effect to some extent in that the second wave peaks are more or less aligned. The healthcare workers are on the right axis and the general population on the left axis. And you can see that the healthcare workers had fewer cases in the third wave compared to the general population once they were aligned in the second wave. So the ratio came down in the third wave compared to the second wave, and it came down even more for admissions, comparing admissions in healthcare workers to admissions in the general population. And if the ratio was the same, the ratio in the second wave came down in the third wave. So we are seeing that gradient effect, but it could also be explained not by vaccination, in the sense that a lot of we know that the seroprevalence in healthcare workers is high, relatively high, and so prior infection could also partially explain the reduction across waves. The Sisonke analysis period that we're looking at was at the tail end of the second wave and into the third wave. So with that, I'm going to hand over to Reshma to just describe the analytic approaches and results.
Thanks, Andrew. Hi, everyone. So we applied 3 analytical methods. So starting with the common elements of those on the left, we studied the association between outcomes and vaccination status as shown. And today we're going to focus on comparing those vaccinated for at least 28 days to the unvaccinated. We used all of the available covariates for adjusting or matching in our analyses, namely sex, age, occupational group, prior infection, time, and the number of previous negative tests, which we constructed as a proxy for risk or health-seeking behavior. And we either analyzed all persons or just those with no prior documented infection. To summarize the 3 methods, in the matched pair analysis, each newly vaccinated person was matched to someone who was unvaccinated at the time and with similar characteristics, and Kaplan-Meier survival curves were then used to compare the subsequent risk. In the adjusted cohort analysis, a traditional Cox model was applied, where the force of infection can vary over time and persons can move amongst the vaccination groups. We also included data from the second wave to establish and adjust for different background risks in those who did get vaccinated and didn't during the Sisonke program. We also used a nested case control study amongst those who do test for COVID, with cases testing positive and controls testing negative, and we applied logistic regression to analyze that data. And the goal here was to compare more similar persons in terms of testing behaviors, but we were limited by the lack of data on reasons for testing. Moving on to the results, on the left, we've got the characteristics of the cohort. So about 3/4 are female and the median age is 40 years. For occupational group, 2 in 5 are nurses and 1 in 5 are management or support staff. Before the start of Sisonke, about half had no previous negative tests, and 3/4 no previous documented infection. And then about 65% got vaccinated during Sisonke. And these people tended to be a bit older, more likely to be in a group that's patient-facing and to have had a prior documented infection. The vaccine effectiveness results on the right. So this is the reduction in the risk, rate, or odds of the outcome in your vaccinated versus your unvaccinated, and the methods generally gave similar results. So starting with severe infection, we had 69 to 84% reductions in risk, looking at those with no prior COVID infection, and slightly attenuated if we look at everyone. The death estimates are highly uncertain because of the very small number of events, but at a point estimate level, it's just above 80%. And then lastly, looking at any infections, we obtained smaller numbers here. The difference is about 30 to 40%. Thanks, Andrew. Back to you.
Thanks very much, Reshma. So just to emphasize the unique attributes of this cohort amongst the number of analyses that are being done on the Sisonke data, is that this is the only one that had a healthcare worker comparison group, even though we are concerned that that comparison group became increasingly unrepresentative over time, as it was a unique group of people who chose not to get vaccinated and became less, we believe, became less similar to the vaccinated and may have been at different risk, most likely lower risk of infection and than those who did get vaccinated. And that it was a common public sector cohort, and that we think our data completeness is relatively good because we do, as a province, receive all of the public and private sector diagnoses and hospitalizations. But there were also these unique challenges. So because the province very explicitly prioritized those who were patient-facing and at higher risk to be vaccinated first, and we don't have access to any data that gives us that risk categorization. We cannot adjust for it. It is difficult to statistically adjust for the biases that we imagine are at play. It's also a smaller study than the others, and so especially for the severe outcomes and the deaths in particular, there's just too few events to kind of explore in the detail that we would like to. And then prior infection, we did adjust for prior infection, and prior infection is a highly very strongly associated with lower risk of subsequent infection. But we know from, in fact, from Groote Schuur Hospital, where they did serology on a number of healthcare workers that I think has been reported at this meeting previously, that not all prior infections are diagnosed, and so there is residual confounding by prior infection, unmeasured prior infection within the study population when we exclude prior infection. But the consistency of findings across analytic methods was reassuring. But we would actually expect to find similar findings, since all methods are working with the exact same cohort. But it is also reassuring to us. Well, firstly, none of the methods, no matter how complex, take away the biases that we've alluded to. We are reassured that, in spite of our concerns about these biases, that the findings of substantial benefit are very similar to what the other groups have found. So the ones are demonstrated, and others which will be reported when these data are fully written up and reported. And then all the analyses were done until the middle of July. And we've had quite a lot of time subsequent to that with quite a lot of events. It was we've had the peak of our third wave subsequent to this. And so these analyses, as we presented them, may not be valid or may no longer hold as we incorporate more data, which we hope to do very soon. And with that, just acknowledgement and thanks. And I think there's just two that I want to mention. For those of us who are healthcare workers in the Western Cape, we are hugely thankful to the Sisonke study that such a high proportion, 2/3 of healthcare workers in the public sector, were able to get vaccinated prior to the worst of the third wave. And then also to the National Department of Health and EVDS team, it's quite a unique resource that the entire country's data are available on one platform, were accessible to us such that we could incorporate it. and then just the very many people who work to make the surveillance data available and have worked to roll out this very incredible vaccination program to healthcare workers and to the general public. Thank you very much.
Thanks very much, Andrew and Reshma, for sharing that data on our webinar, sort of highlighting it for the first time on this webinar. Andrew, if I can just ask one brief question. You referred to the biases in the data, and most of those biases would result in an underestimate of vaccine efficacy, do you think? You're still on mute, I think.
Yeah, there you go. Okay. Yeah, I think you're right, Graham. So in our study, we really do believe that that cohort of unvaccinated people that we're comparing to did become less and less representative over time. And so it would bias towards a null. So it would underestimate the true effectiveness. And I think the infection estimate is probably the least reliable because of it's probably the most prone to that bias. And it sits at the lower end of what others have found. So the other groups haven't yet reported their infection estimates, but I think ours is a bit of an outlier. Mm-hmm. And then for the other studies that have compared to non-healthcare workers, they've gone to extreme lengths and done remarkably well to try and demonstrate that the people who are unvaccinated are at similar risk in that period prior to when you expect the vaccine to be effective. So they look at from about days 5 to days 11 or 12, when the kind of we expect to see some similar risks in the vaccinated and the unvaccinated, and they show that their matching has been good because there are similar risks. But even still, the fact that they've matched to people early on in the vaccination program, and then we've moved into the third wave, and it's still possible that healthcare workers come under a greater force of infection than the unvaccinated twins or counterparts, even if they had similar risk at that period where they demonstrate similar risk. So I think both our analysis and the other analyses, for different reasons, probably are biased towards lower effect, reflecting low effectiveness.
Great, thanks very much to both of you. So we're going to move on to our next speaker, and it's a great pleasure to introduce Jeff Klausner. Jeff is a professor of population and public health sciences and medicine at the University of South California. And Jeff has a connection to South Africa between 2009 and 2011. Jeff was branch chief of HIV and TB at the CDC in Pretoria, and was involved in leading South Africa's PEPFAR program for HIV care and treatment, and it's very instrumental in the scale-up of cryptococcal antigen testing and screening in South Africa and other countries in Africa. Jeff's going to be discussing today fluvoxamine, which is obviously something that's been in the news recently on account of it being shown to have efficacy in the treatment of COVID in an outpatient setting. I'm going to deal with some of the mechanisms by which fluvoxamine is thought to have action, and also discuss the results of the Together trial and other clinical studies that have looked at the efficacy of fluvoxamine. So, Jeff, thanks very much for the early start to your day in California and joining our webinar.
All right. Well, thank you all for inviting me. Is everything set with the correct screen?
The screen's up and we can hear you, yeah.
All right, excellent. Well, it is a major disappointment for me not to physically be in Cape Town, but so be it that I can do this from my home in Los Angeles. So I'm going to give about a 15-minute overview of fluvoxamine for the treatment of COVID-19, what we think we know about mechanisms, and then the clinical evidence. I have no specific financial disclosures. I will discuss investigational use of medication. Fluvoxamine, as many people know, is a potent selective serotonin uptake inhibitor, or an SSRI. It was first introduced in 1983 for the treatment of depression. It was approved by the US FDA in 1994, and also has indications, at least in the United States, for the treatment of obsessive compulsive disorder. There's been newer SSRIs which have generally replaced fluvoxamine, but fluvoxamine for decades was a real go-to medication for treatment of different psychiatric disorders. Obviously, there's significant advantages to repurposing generic medications. The safety record is well known. For fluvoxamine specifically, there's few adverse effects when they do occur. It's usually mild nausea, some difficulty sleeping, so it's recommended people cut down on their coffee intake. It is inexpensive and widely available. It's easy to use. And then particularly for the management of COVID-19, it's highly lipophilic with rapid uptake into lung epithelial cells. So there are at least three potential mechanisms, and I'm going to go through each of these three in a little bit more detail. So one, it was discovered that fluvoxamine actually is a potent anti-inflammatory, and it reduces inflammation through activation of a sigma-1 chaperone protein, which actually leads to a reduced endoplasmic reticulum stress response with then subsequent reduced cytokine production. And as we know in COVID-19, part of the morbidity is to excessive inflammatory response. There's a second proposed mechanism through inhibition of viral entry by blocking a specific enzyme, sphingomyelinase, which is relevant for viral entry. And then thirdly, in general, SSRIs have action that reduces hyperactivation of platelets and mast cells, which may reduce clotting and thrombosis, another complication seen in COVID-19. So in terms of sigma-1 activation, it's felt that this sigma-1 receptor, when it gets activated in the nucleus in the endoplasmic reticulum, it reduces NF-kappa beta activation and then subsequent production of cytokines, particularly things like interleukin 6. And we've known that there's been a variety of studies with cytokine inhibitors or modulators, which have not necessarily been directly that successful for the clinical management of COVID-19. Second, and then this actually was shown in a nice study reported in Science Translational Medicine in 2019. So about a year before the pandemic, investigators were looking at the role of fluvoxamine in its anti-inflammatory effect, and they were able to show that mice, a mouse model where they expose mice to what they call fecal-induced peritonitis. So I think you can figure out, what that is. And then they basically pre-treated the mice with fluvoxamine or control with saline, and you can see there was a marked improvement in survival in the fluvoxamine-treated mice. So there does seem to be, a inhibition of this inflammatory pathway and mortality benefit that was directly showed in the murine model. So the second mechanism is through this inhibition of sphingomyelinase, which is felt to be key in cell entry. There's been in vitro studies which showed a reduced infection in cells that were taken from individuals who had some kind of pre-medication with these inhibitors. And the data I would say on this is a bit less compelling than the inhibition of the anti-inflammatory pathway. And then the third mechanism, as I mentioned, is related to the inhibition of serotonin release, and then the reduction in platelet and mast cell activation. So let's move from the mechanisms to clinical data. So there's really been three studies that have been reported that I'll cover. There's some additional studies that are ongoing. So the first study that got the field excited was reported in JAMA, Journal of American Medical Association, in November 2020. And this was a study led by Eric Lenz from Washington University School of Medicine. And it was really him and his colleague, Angela Rarison, who came up with the idea that fluvoxamine might be a useful anti-inflammatory in the management of COVID-19. And because of the stay-at-home orders at the time, they actually did what's called a no-contact study. So they basically enrolled people through the internet, and they mailed them medication. They did follow-up by telephone or telehealth, and there was no direct interaction with the study participants and study staff in the clinic. So that was actually somewhat novel in terms of a clinical trial in the US. So this was called the Stop COVID trial. Hypothesis was that fluvoxamine given early in COVID-19 would prevent clinical deterioration. Participants in this study were 18 years or older, had to be COVID-2 positive. Importantly, they were community dwelling. They had to be symptomatic, but for fewer than 7 days. And people were randomized to either fluvoxamine 100 3 times a day or placebo. Now, we don't know what the best dose or best schedule is. So investigations have done 100 twice a day, 50 twice a day, and that's still work in progress. For this study, the primary outcomes were clinical deterioration, which meant shortness of breath or hospitalization with a decreased O2 saturation. So here you can see the primary outcome in these 152 individuals in the fluvoxamine group. There were 0 who deteriorated, which meant were hospitalized. And then in the placebo group, it was about 8%. So this was reported as an early, pilot study, promising for the potential benefit of fluvoxamine. The adverse events in this group were fairly equal. There was obviously worse clinical events in the placebo group. So based on that report, which came out in mid-November, a South African physician, David Seftel, who is the, let's call him the physician-in-chief of a racetrack in Berkeley, California called Golden Gate Fields, where, there are a few hundred workers at this racetrack, was trying to manage an outbreak of COVID-19 among employees at this racetrack. So part of their control strategy were to continually test employees in multiple rounds of mass testing. In this period in end of November 2020, they found 113 new cases by rapid antigen testing, which were confirmed by PCR. And because this physician was well trained by the South African medical system, he decided to take the pilot data and do his own study. So he offered to the 113 individuals fluvoxamine. A little bit more than half accepted fluvoxamine, and then 42% did not. He gave different doses of 50 or 100 twice a day for 2 weeks. And this is reported by our colleague David Boulware in Open Infectious Diseases in February 2021. The characteristics of these 113 individuals, about a third were over the age of 50, about a third had some type of medical comorbidity. Remember, all these are outpatients. They had to be somewhat symptomatic, but about half in the cohort were actually asymptomatic. And majority of these workers were Latino or Latin men, predominantly from Mexico. So the clinical outcomes, so in terms of the fluvoxamine group, 0 were hospitalized, and then 6 out of 48, or about 12.5%, who did not get therapy. Remember, this is not a placebo-controlled study. It's not a randomized study. It's just kind of allocated by who wanted medicine and who did not. And then additionally, at day 14, 100% who got fluvoxamine were completely asymptomatic, versus about 60% of those who did not get therapy had some persistent symptom. So now we had 2 studies, 1 small randomized controlled trial and 1 observational study, suggesting potentially a profound benefit from fluvoxamine. And at the time, we convened an NIH study group to review these studies, review the mechanism of action. And the conclusion in January at the time was to continue to study and not make recommendations. But then came the Together trial, and the Together trial, as some people may know, is a massive multi-center adaptive randomized platform trial to look at a variety of interventions like hydroxychloroquine, ivermectin, and also looking at fluvoxamine. So they introduced fluvoxamine into their study in January 15th, 2021. They did an analysis cutoff on August 2nd, so about a month ago. and I'm going to share it with you findings from their study. The study is led by Ed Mills from Canada and is implemented in Minas Gerais, which is a province in Brazil. So the inclusion criteria for this study, you had to present to an outpatient care setting with acute clinical condition consistent with COVID-19. Again, symptoms had to begin recently within 7 days. You had to have a positive microbiological test, a rapid test for COVID antigen, and then you had to have at least one condition which puts you in a high-risk category, which would be a comorbid condition, additional illness, or age greater than 50. And I think it's important, most of these studies really have found benefit in a higher risk population, either older population or population with comorbid conditions. Exclusion criteria, so if you were hospitalized, if you have been vaccinated, if you had severe oxygen desaturation, if you're already taking SSRIs, potentially relevant for South Africa, if you were on antiretroviral therapy, you were also excluded. Pregnant, breastfeeding, had a history of arrhythmias, liver disease, diabetes, seizures, or daily or uncontrolled alcoholism were exclusion criteria. The main outcomes, so they had actually a composite primary outcome. So their composite primary outcome was emergency room visit, which was defined as clinical worsening with a participant remaining observation for at least 6 hours, or hospitalization. So you had to have either a ED, emergency room visit, or hospitalization to meet the primary outcome. And then they looked at a variety of secondary outcomes. So the baseline characteristics in this group of 1,480 individuals, a little bit more male than female, age about 48 years of age, and then about 18% overall had 2 or more comorbidities. So here's the primary outcome data, and the way they reported this was kind of this Bayesian analysis. So they reported the posterior probability of superiority of fluvoxamine versus placebo on emergency room observation for 6 hours or hospitalization. So as an epidemiologist, I thought it was just kind of interesting the way they presented the data. So on the left, you can see the distribution of the red is the fluvoxamine group in terms of the event rate, and then the right side is the placebo group in blue. We may be more used to seeing the effect sizes on the right with the 95% confidence interval. So you can see the event rate on the blue group, where the placebo was 0.146, or about 14.6%, versus about 10% in the fluvoxamine group. And then here you can see they reported the relative risk. You see the number of patients allocated to each arm, and then the number of events. And this was analyzed as an intent to treat analysis. And you can see a 31% reduction in risk for that clinical outcome of emergency room or hospitalization. Then they did some additional sensitivity analysis, and they looked at participants with at least 28 days of follow-up. And you can see that they still retained a large proportion of the cohort. It's still 90% of the cohort, and the relative risk is the same, about a 30% reduction. And then they also looked at individuals who received at least 1 day of treatment. And perhaps not surprisingly, this is a little bit more potent, so about a 35% reduction in people who received at least 1 day of treatment. Some people did stop because of some of the side effects I mentioned, such as nausea or difficulty sleeping. Dry mouth has also been reported as well. And then they looked at mortality, and the study was not powered for mortality. The number of events were low, but you can see a very similar point estimate of about 29% for a potential reduction in mortality. So the Together trial had a large number of individuals and groups that supported it. Ed Mills, as I mentioned, and Gilmore Rice were the principal investigators. Angela Rierson here, under senior investigators, is really the psychiatrist at Washington St. Louis who came up with the idea of using fluvoxamine. So in summary, fluvoxamine may benefit outpatients with newly diagnosed SARS-CoV-2 infection. And I will end there. Thank you very much.
Thanks very much, Jeff. That's a really fascinating overview. We will ask for questions in the chat function, and we'll take them in a question session at the end. But I just want to ask one question now. You know, in your kind of personal opinion, what impact will these findings, you know, and particularly the findings of the Together trial, have on clinical practice in the US, and perhaps the NIH guidelines on treatment of COVID?
Yeah, so I think, I mean, it is already affecting clinical practice. So we're starting to see increased prescriptions, you know, particularly in people who have risk factors for deterioration. We've seen regular kind of media announcements and interviews and stories about it every day now. So I think the needle is actually moving. I can't obviously speak for the NIH, but when I convened a group of a lot of the NIH participants on that advisory board in January, my idea at the time was to try to prime them. So when a clinical trial came out that was favorable, they'd be more quick and able to make a decision. So I'm expecting perhaps this month they may come out with you know, recommendations to consider fluvoxamine, particularly people at high risk for deterioration.
And are there any other ongoing trials at the moment?
Yeah, so David Boulware in Minnesota has the adaptive trial, which is ongoing. There was another trial which Eric Lindsay at Washington University St. Louis had done to kind of replicate his Stop COVID trial, but that was deemed to be futile because of lack of enrollment, because that was done, you know, kind of in the spring of 2021 before this summer fourth wave, and its trial was stopped in end of June.
Okay, great. Thanks very much, Jeff. And as I said, we will have some questions, further questions after Chris's talk. So then to move on to our next speaker, and this is again a great pleasure to introduce Chris Butler. Chris is a professor of primary care at the University of Oxford, and is a graduate of UCT, as well as an honorary professor appointed in the Division of Infectious Disease and HIV Medicine at UCT. Chris is very well known for many studies that he's led, looking at interventions in primary care, large randomized controlled trials, over 30 that have impacted practice globally. And he co-leads the principal trial of community treatments for COVID-19. And this afternoon, he's going to be talking to us about the findings from that trial with respect to inhaled budesonide and the benefits in treating outpatients with COVID-19. So thanks very much, Chris.
Thank you very much, Graham. And it's just wonderful to be with so many valued colleagues, and also sort of reflecting my links with the University of Cape Town and South Africa. So in any case, I'll be talking, as Graham said, around findings from this principal trial, which is the platform randomized trial of treatments in the community for epidemic and pandemic illness. And this is I think a timely presentation, because despite high rates of vaccination in some countries and increasing vaccinations worldwide, the new cases are still there. And I think we recognize that we will need acute therapeutics, even although we have good vaccination and from time to time the effects of lockdown and so forth. Just a bit of background, I think everyone knows that most people will be managed in the community, and although it's very important to have treatments that sort of snatch people back from the jaws of death, it's perhaps equally, if not more important, to have treatments that prevent them getting to the jaws of death, shall we say, In other words, treatments that help people recover quicker, reduce spread, and prevent hospitalization. And we therefore, along with many others, set out to evaluate whether repurposed drugs, in principle, could make a difference with an earlier intervention. And the trial design will be of interest because, we didn't do a traditional trial design because we knew that there would be new treatments coming down the line that we would want to introduce into the trial. So we needed to get answers quickly, and we needed to be flexible in order to add in new treatments as they emerged. And we managed to randomize our first patient within 3 weeks of our initial contact with the Deputy Chief Medical Officer in the UK who spoke about doing the study. So just a quick word on the design considerations of principle. It's a kind of pragmatic trial trying to reflect real world care as much as possible. It's not placebo controlled, and I'll say a word about that. The platform trial aspect allows both sort of evaluation of drugs in parallel and sequentially. And we use a response adaptive randomization, which means that if a particular intervention is doing better, in the background, the algorithm will allocate more people to the better performing arms, excuse me, which has certain advantages. Firstly, you get an answer quicker, it's more efficient, but also more people within the trial will get the chance to get the better performing treatment. A lot of people, excuse me, will say, well, look, a trial isn't worth its salt if there's no placebo. But I would push back on that and say that it depends what your question is. If your question is, does the treatment work better than a dummy version of the treatment, then you definitely need a dummy version of the treatment as your comparator. But if your question is, I'm a clinician sitting here, I've got a patient in front of me, do I add in the treatment versus not adding in the treatment? Then no placebo is the right scientific approach, because you're not going to add in a dummy version of the treatment. In primary care, we don't prescribe placebos, or we claim not to. And so pragmatic studies should ensure that the comparator group is as close to what you would do in real world usual care as possible. Now, this does not allow us to determine what proportion of any benefit is created by the placebo. In other words, the mechanism is not elucidated. But nevertheless, it'll tell you the overall effect of doing something versus not doing it. To get down to the sort of participants in the trial, we are able to have varying inclusion criteria relevant to the particular intervention. So, some of the treatments in the trial have been limited to those particularly high risk, and some of them to sort of all comers. For example, with ivermectin, which is currently in the trial, anybody who's still sick, who's over 18 with a positive test within the past 2 weeks can be eligible for that. But for those getting other treatments, we've limited to people over 50 and over with comorbidities, or anyone over 65. And I'll just say a little bit about the trial design. There's no set number. So this schema here, figure 1, is a sort of summary of what you might do in a traditional 2-arm trial, where you throw the bones, come up with a sample size calculation, you get a set number of patients, and you keep recruiting till you hit that number, and you see who responds and doesn't in the 2 arms. So you've got a fixed sample size, whereas with this platform approach, you kind of start the trial without putting a limit or a minimum cap necessarily on your sample size. And you do regular interim analyses. You might allocate more people to the different treatments based on their response. And therefore, at a certain point, if you hit a threshold for futility or success, you can then drop those treatments and add in new ones. And you can see after outcome review 2 here, intervention 3 is doing very well. So that gets an answer, and we keep recruiting to intervention 2 because we haven't quite reached that pre-specified threshold, and we can start introducing more treatments as we go along. It also uses Bayesian analyses and a kind of gatekeeping approach. And we kind of hypothesized, because we wanted answers quickly, that if something isn't helping you get better any quicker, it's unlikely to reduce your hospital admission rate. So we only start to look at hospital admission rate if we start to see benefit in terms of recovery. And for that, we call that a gatekeeping approach. Now, in terms of trial delivery, this has kind of been hinted at before, where traditionally in primary care in the UK, at any rate, we set up general practices as sites, but there's about 8,000 GP practices in the UK, and each one of them will have a requirement for a contract and GCP training and so forth. In the recovery trial, they got less than 200 hospitals. You can have a single contract covering them all. And setting up these sites is very time consuming. Not all of them want to be part of research or can be part of research. And a lot of people don't get their healthcare from those practices, or might turn up on the day that the research interested GP is not there. So we have opened up well over 1,000 GP practices as sites, but we are also using this model of taking research to the patient, where people can register online. We can use a thing called the summary care record to confirm eligibility, and then courier medication to them, as has been done in some of the trials that have already been mentioned in the US. So in that sense, we kind of see ourselves as the first truly democratic, nationally inclusive trial of an acute condition for the UK at any rate. And this is how the recruitment has gone. The orange represents those with a positive test, and they all now have a positive test, whereas in the first wave, we weren't able to test because swabs weren't available in the UK. And we do analyses in the past, looking at everybody meeting syndromic criteria versus those who met, who tested positive. And now our primary analysis population is those with a positive test. These are the general practices that have recruited at least one participant. And here's, I guess, the timeline of the trial, starting out with hydroxychloroquine. And then we introduced azithro and doxycycline and showed that those did not materially benefit people with the condition. The inhaled budesonide, I'll say a little bit more now, and we currently, we stopped the colchicine and for futility, and gosh, I've used a little bit of an outdated slide. We've had favipiravir in the trial and ivermectin in since June. Great thing about the NHS is that there is a potentially single line of communication. So the Chief Medical Officer through the Department of Health and Social Care can send out these therapeutic alerts, and together with findings from the recovery trial in principle, every clinician in the country got an alert not to use these drugs for COVID in the absence of other indications. Now, to cut to the chase here on the budesonide, I'll just mention that this is what I'm going to show you is the results for the final analysis, not interim analysis. And this covers 787 people on budesonide with a positive test, 1,068 with the usual care, and we leverage power, shall we say, from people who had other interventions, and there's 674 of those. So just looking at the time to first reported recovery from the patient. In other words, the patient is telling us, I'm now completely better. We find a probability of superiority of basically 99.99%, with a hazard ratio 1.2. What that comes out to be is that on average, if you didn't take the budesonide, it was 14.7 days to first report of recovery versus 11.8, giving you an average of 3 points of difference. But now, if you look at just those who looking at the hospitalization, we also see a 2% difference here, but we didn't quite meet the probability threshold for superiority. If you look at everybody with a positive test. However, if you look at just those who got budesonide and those who didn't get budesonide with a positive test that were recruited at the same time, because we use controls that were there before a drug was introduced, we leverage information from those, we do find that the a probability of superiority does meet our pre-specified threshold of 0.975. So that does become a statistically significant difference in the subpopulation, the 2.2% difference. It's a number needed to treat of about 50, which I'll leave you to think whether that's worthwhile. But critically also, over 28 days, we find a roughly 50% relative benefit, 10% absolute benefit in terms of those who say they get better and then stay better, because as we all know, it's a bit of a bumpy ride recovery here. But we're very concerned about recurrence and getting sick and staying sick. So sustained recovery was much improved. And also a sense of well-being. We used the WHO index of well-being, as well as just asking people how sick they felt on each day. And contacts with healthcare, apart from hospitalization, were also significantly reduced. We looked at any subgroup, we looked for subgroups that might benefit more than others. And basically what this shows is that, you know, there were similar benefits across the piece, regardless of patient characteristic. And for hospitalization as well, there was no sort of dramatic difference, but you could say that if you look at the over 65s, that was a significant difference in hospitalization rate benefiting them. So look, in summary, I'll just focus on the inhaled budesonide. I mean, I think firstly, the trial has shown some innovations in trial design, in the way we've delivered trial, and also in enhancing the evidence base. But for the budesonide, we find that people will recover if they use it on average 3 days quicker. While they're recovering, it's not just those 3 days that you save, but while you're sick, and for those of us who've had it, you can feel very sick. You're going to feel less sick if you take the substance. You're going to better well-being. The chances of you relapsing are less. You'll consult less often, and there's a high probability that you'll need to be hospitalized less often as well. And there was the NICE in the UK sort of said, fine, based on the interim analyses, you can prescribe the stuff off-label to those who were in the trial, and that's the age 50 and over with comorbidity, or anyone over 65. So just in summary then, so far overall, we're around about 6,200 patients randomized in the trial. Our colchicine analysis is under review at the moment, and we're recruiting 3 ways between usual care plus Favi and ivermectin. So thank you very much, Graham.
Thanks, Chris, for sharing the findings of this really important trial with us, and really exciting to see yet another option for treating patients in an outpatient setting. I'm just interested, whether you think and whether you'll be able to ascertain the effect of budesonide on long COVID symptoms. I think you hinted at that to say that, patients recovered more rapidly and there were fewer visits to healthcare practitioners. But will you be able to look in the longer term if it has an impact?
Yes, we continue to follow up the participants in the trial at 3, 6, and 12 months. And we're getting ready now to do an analysis of the 3-month follow-up, which again will be critical to see if there is any impact on symptoms and COVID-related illness at that point.
Yeah.
So that's forthcoming.
Okay. Mark, can I ask you, or Mark or Wendy, are there questions that have come in through the chat?
So we've got a couple of questions. The one is fluvoxamine the only SSRI that should be considered in treating patients with COVID? Or can we use any of the others that might be cheaper? And then is fluoxetine a possible alternative to fluvoxamine?
Right, so all the SSRIs are not created equal, and some of them were actually a mild antagonist to this sigma-1 activation chaperone protein. So the best evidence for inflammatory effect is actually with fluvoxamine, and there have been some observational studies in France which show that people on other SSRIs were a little bit more protected, but the best evidence is with fluvoxamine as the best evidence for the mechanism of action and clinical outcomes. So the short answer is probably not.
Could I just come in there? I know I'm sort of scratching in another person's salad a bit here, but the anti-COVID trial, which is an African-based trial, is about to open, I think, with fluoxetine plus inhaled budesonide. So that'll be really interesting as well.
Do you know which countries that's being done in, Chris?
Look, I think there's about 10 countries where they're going to, and they're already, I'm not sure if they're recruiting to that arm, but they are recruiting to their other arms.
And then there's a question regarding the dose of budesonide used in the trial and whether there's any information relating to dose selection and duration of therapy.
Yes, so we used, the duration was 14 days, and we used 800 micrograms twice a day. So it's quite a high dose of inhaled budesonide. And, the rationale for that really came from a smaller trial called a STOIC trial, of about, I think it was about 140 people in there, which showed efficacy. So we just, and low in fact, no side effects. So we followed that regime.
Sorry, Chris, can I just ask, in the trial, I may have missed it, was it just standard inhaler technique, or did you encourage people to use a spacer?
No, one of the reasons why we chose budesonide, in fact, is because it comes in a sort of turbo haler. And this is a fairly simple device, people know, where you can kind of just click it. So you don't need a lot of coaching for this. And obviously for distribution of drug and just getting older people who are quite sick, if you're doing an online trial, if you like, to get them used to a spacer plus the inhaler plus the techniques, we thought that we would avoid that and went for the turbo haler option of budesonide. So that was another reason for choosing it.
Thank you.
I think that's all the questions in the chat at the moment, Graham.
Okay. Just if anybody else has questions, please just post them, and they come up for Wendy and Mark to post. If I can ask Chris a question, are there any insights as to the mechanism through which budesonide is having its action from either the principal study or other studies that have been done? Yeah.
So look, I think that the first thing I would say is that apparently there's a downregulation of the TMPRSS2 receptor, and this government health warning, like I'm a GP talking like I know about cell receptors and stuff, but to put it in simple terms, as I understand it, downregulates the receptors for which the virus uses to get into the cells. Obviously, it's anti-inflammatory within the lungs, and a certain proportion of this would be systemically absorbed. Not in great quantities, but I believe up to about 5% will. And, there's also the potential for systemic anti-inflammatory properties, as well as the well-known effect that steroids often make people just feel a bit better. So there could well be a antiviral mechanism through blocking entry into the cells and, general anti-inflammatory cells, anti-inflammation, both locally and systemically.
I mean, it's just interesting that the recovery trial didn't show any benefit from systemic corticosteroids.
Yes.
In those not requiring oxygen, which is this patient population. But I guess it's a very different endpoint that you're looking at.
Yes, and of course, we thought about giving systemic steroids, but in the primary care population, we've got to acknowledge that most people who get this condition will recover unscathed, we hope. And giving them heavy-duty systemic steroids in the face of a viremia was something that we were reluctant to do. Whereas if we could localize the steroid to where the main site of infection was, then we thought that would be better. So the inhaled steroid we thought might work in similar ways, but might be less prone to giving adverse effects. So it's more kind of suitable, more of a primary care treatment. Plus, GPs are used to using this drug and we know it's exceedingly safe, scalable, and widely applicable, and patients are used to it too.
There are two more questions, Graham. So in terms of the trial design, how do we account for individuals taking over-the-counter meds that might be accounting for some symptomatic relief? Can you account for?
I think that's for both studies, really. For the fluvoxamine study that was, the initial one spoke about online. How do you stop people from using con meds?
Well, I'll just, I don't want to jump, but I'll just say that we don't. We assume that randomization with reasonable numbers will take that into account. We do measure adherence to the drug, just self-report. And, I suppose an important thing would be in the control group over time, we get things like vaccination, lockdowns, variants coming. So the outcomes can change over time, and they do. They do change quite dramatically. People, if you look at it month by month, the time taken for recovery is different. So we use in the Bayesian model, we take time into account. So if we're finding particular remedies might be used more often in certain circumstances or at different times, then adjusting for variation in outcome over time is considered in the model.
Yeah, I would say, in a placebo controlled trial, that's kind of one of the reasons you randomize is for these, cofactors. You can't control concomitant use of medications. I mean, even if they were enrolled in a clinic and then they went home, you couldn't really control that as well. But the idea is that, there'd be equal use of that, and that may, mitigate the effect. So when you do find a significant effect size, that may be an underestimate.
And then there's just a comment from Prof. Bateman saying that 1,600 micrograms per day of budesonide is equivalent to about 10 milligrams of oral prednisone. And then just the comment that there's some evidence that topical applications in airways diseases like asthma have additional benefits over systemic corticosteroids. So just saying that budesonide might have additional benefits.
Yes. Thank you.
I think that's all from our side, Graham.
Okay, Jeff, one last question from me. Just out of interest, do you know if they're going to be able to explore some of the mechanisms in the Together trial? Have they got samples that they can look at the immunological effects of fluvoxamine?
Yeah, so that's actually a good point. Is that's the limitation of these kind of no contact trials where people don't, come in for follow-up, is we're not collecting blood specimens, for markers of, cytokine or the, proteomics. So for that trial, no.
Okay. Okay. So then just to wrap up and to say a big thank you firstly to Reshma and Andrew for sharing the local data, and then to Jeff and Chris. I think this has really been an important session addressing, I think, what has been a key challenge, particularly for colleagues working in primary care during this epidemic, is that there haven't been therapies that can be offered to patients who are diagnosed with COVID. They know that there's a risk of being hospitalized. And there haven't been the evidence-based strategies to hasten recovery and to prevent hospitalization. It's really been fascinating to hear about these two options for which there is evidence now from randomized controlled trials. So very grateful for you for joining the webinar today, and really excellent talks, and thanks very much. And thanks to the audience, and we'll be back in 1 month's time.
Thanks. Thank you, everyone.
Thanks.
Bye.
Yes.
Thank you.